So we were planning to have, hi, Dr. Suresh, I was just about to introduce you.
Okay.
We were planning to have two faculty for today's session. And as Sripriya mentioned, today is about renal issues in palliative care setting. So many of us see patients with renal issues, but I feel we don't feel confident enough to manage those patients in our setting. So today's session is going to be very informative for all of us, hearing it from the nephrologist. Dr. Suresh is the Vice President Clinical Affairs in with NephroPlus. NephroPlus is uh, largest dialysis center network, which has almost 300 centers in 4 countries, including India, and he has almost 2 decades of experience as nephrologist with NephroPlus. Today, we were expecting Mr. Kamal Shah, who is on the receiving end of all this that we give. He's been on dialysis for the last 25 years, and he has gone through all the modalities, and he's currently on the daily nocturnal home hemodiafiltration. He's again a co-founder of NephroPlus. I understand that Mr. Kamal is not keeping well, but Dr. Suresh will take us through his journey. Mr. Kamal, those who are interested, he has an interesting blog about his journey through dialysis over 25 years. So he has written many of his experience in that blog. So you can just Google and read whoever is interested to learn more about Mr. Kamal. Thank you, Dr. Suresh, for coming for this program. This is about 30 plus doctors who are actively working in palliative care, and many of them are working in a community-based setting. And many of us see patients with kidney issues where we are kind of not very competent enough to manage on our own. So we are really looking forward for this session. Welcome you, sir, for today's session.
Thank you. So just by thanks for the introduction, I think I also should say that it's a first time around that I'm interacting with palliative physicians group, and I think big thanks to Dr. Rajgopal and Pallium for getting this interaction on. Just being curious now, where are all the docs in terms of their instant practice in care? I mean, I see it's a large group. Are they all around India, or just to get a flavor of where people are?
Yes, almost all around from India. Tamil Nadu, mostly from southern part of India, but almost all places from India. And all of them are practicing palliative care physicians for past many years.
Okay. And I guess they're primarily or other specialists and other things, and palliative care is an added component of their professional life. Am I right?
I think most people in this group are specialists in other specialities, but they work mostly in palliative care. They've, I think, transformed into palliative care physicians, most of them.
That's amazing. So great. So let's get going. So, as Sridevi has said, that Kamal is unwell. In fact, he's got a infection of his dialysis access fistula. He's doing high grade fever, and he called me just an hour ago, and he's on antibiotics. He's just unwell. So anyway, let's get going. If I can share my screen, and so I should take that. Coming. Okay. So the first part of the today's talk is more what I will talk in a broader sense of the kidney disease landscape, and also give you a sense of some basic clinical medicine and CKD issues, maybe fundamental, but I think that is kind of the background in which how you need to approach. We'll specifically talk about, I think, survival on CKD and determinants, what determines survival. And I think that will be a good backdrop. And I'll share with you 3 scenarios that I've handled, and it brings about all the talking points in case management. I think this is a reality that all of us are seeing in India over the last 20 years. Clearly, non-communicable diseases, mortality is much higher than communicable diseases. I think the crossover happened maybe 15, 20 years ago. But I think what is important is, as we go through these lifestyle issues leading to diabetes and hypertension and cardiovascular diseases, which is which seeing strokes and heart attacks, kidney disease is sort of coming into the picture. And why what I want to highlight is the clustering of the diseases. And what is so typical with kidney diseases in terms of scale, this is just a rough Venn diagram. In terms of scale, kidney disease is much smaller in terms of the magnitude of the problem, but it kind of remains silent and hidden behind these. And when I say silent and hidden, it's hidden from patients' knowledge and perspective, the general public's awareness of kidney disease symptoms and reason to check for kidney disease. Again, even from physicians, it's not adequately emphasized. So very often when a kidney disease is diagnosed, it's not in the early phase. There is data from the Indian CKD registry that shows that 60% of kidney disease patients, we're talking about chronic kidney disease, see a nephrologist only when they are past moderately severe damage. And I'll tell you what moderately severe damage is. So I think that is the key thing, right? But what is also happening is kidney disease is rapidly moving up the ladder of ranking with regards to where it stands in the burden of diseases in India. It was somewhere in the teens in terms of causes of death. Now it is below the single-digit numbers, and it's expected to rise. So we're all going to see a lot more kidney disease as the NCD epidemic unfolds. Fundamental issues on kidney health, and I have this slide mainly just to refresh your basic kidney function and physiology, and we'll connect it to what patients will experience in advanced kidney disease, and what are the interventions that we ought to do. I think what is one part is what is called the kidney's excretory function. We are aware of excretion of protein metabolites, excretion of salt, excretion of acid and water, right? So these are all excretory functions, right? And there are two synthetic functions that you have to bear in mind, which is synthesis of erythropoietin and hence hemoglobin, and synthesis of activation of vitamin D, which influences calcium balance and bone structure. Now, why you need to keep in mind is when you're looking at a patient, patient symptomatology, particularly in advanced kidney disease situations, can be very variable. There could be patients only with fluid and salt-related presentations, which is called body swelling and breathlessness. At other situations, patients may just have very profound bone-related symptoms and skin-related symptoms from hyperphosphatemia, and they won't have the fluid-related. Some patients might have none of this, and they'll just have bad effects of azotemia. And once in a while, a patient will just have a cardiac arrest from potassium. So which of this manifests in which patient, you do not know, but you need to just keep in your frame of mind. There is the excretory function of the kidney of metabolites, which we always, it's urea is what is always kept in mind, but nephrologists follow creatinine. There is excretion of salt and water, which is the fluid balance. Then there's excretion of potassium and acid, which is related to bicarbonate level and acidity of the system. So keep this framework. We'll come back to when we talk the case management. The next thing is how common is kidney disease, how big it is. This is very, very simplified information I'm providing you. I think all of you should know that acute kidney injury and chronic kidney disease are the appropriate terms and not ARF and CRF like how a lot of us might have learned just from this, terminologies and this thing. AKI and CKD, I think those are the terms I'll be mentioning. Sridevi, at any point, if anybody wants to interrupt, just tell them to raise a hand on Zoom. We can always slow down.
Yes. I'm looking at the chat.
Yeah. Just feel free to interrupt. So, so I think that's the thing. And in terms of prevalence, if you compare to diabetes, which is 20% of the adult population, or in the urban context, or hypertension, which is somewhere in that range, or even higher in certain contexts, coronary disease, which is in percentage, kidney disease is much, much lesser, which is why when you saw the Venn diagram, the kidney disease is a much smaller problem. Now, this is our participants in the group familiar with this staging and this terminologies of CKD 1 to 5? Is anybody can anybody respond unmuting? Are you familiar with this concept of CKD staging, and is it something that you use it as a lingo in talking to doctors and nephrologists, or is it all new to all of you? Anybody?
I think Dr. Punita was mentioning that she has a lot of patients on renal transplant in her setting. Dr.
Okay.
Punita,
Go ahead, Punita.
yeah, two people have responded, Dr. Meka and Dr. Punita. Both of them have responded yes.
Okay, fine.
Hello, we are new to this. I'm new
Okay.
to this.
You're not it. Okay. So, just historically, in nephrologists globally, this is about 10, maybe 15 years ago, felt there was just a lot of noise around CRF and what is mild, what is moderate, and everybody were meaning different things. So renal and failure and end stage disease, all of them had a very distorted way of describing something simple. So they came up with this chronic kidney disease, CKD. So it is all simple and everybody to understand. And the next thing they came up with was, let us divide it into stages. So just like, there's New York Heart Association, there is, for COPD, there's GCS, so on. Let us get kidney disease also into simple terminology and stratify into stages. Now, here comes a little bit of difference, that the stages is based on a GFR level. Now, GFR is not something that all of us can measure it in our practice and in our clinics. We measure blood numbers and the next thing is, if you want to think of GFR, the cornerstone is looking at your creatinine. So urea doesn't get weightage in kidney disease severity assessment. It's got to be creatinine. And creatinine can be used to estimate your GFR, right? How do you do it? I don't want to spend time on this class. There are various formulas. There are a couple of them that are mostly used. But again, like everything in the world, if you're using a phone, you're using it, any MD, MedCalc or any of the apps, you enter age, creatinine, and race, it will tell you your GFR. Labs nowadays, certain labs actually give you a creatinine and then give an estimated GFR. Essentially, you're able to say, okay, fine, I'm dealing with a stage 3 or a stage 4, whatever. I think the context for this group, the big interest will be in stage 4 and stage 5. That's where decisions will be made. We'll talk about it when we present the scenarios. Essentially, there are 5 stages of kidney disease. It's GFR based. GFR is estimated by measuring creatinine. You can convert creatinine to GFR by 2 formulas if you want to make a note. One is called the MDRD formula, MDRD, which stands for modified diet in renal disease, which is and then the other formula is called the CKD-EP formula. You can look it up, but all these formulas are inbuilt in apps, and you put the patient's gender, age, and creatinine. These apps give you GFR. It tells you how severe your kidney disease is. I think that's the key part. When it comes to symptoms of kidney disease, it's good to kind of think in your head, what am I dealing with? Am I dealing with symptoms related to the urinary tract? Or am I dealing with symptoms because of the low kidney function on other body systems? Or am I dealing with what is disturbing the kidney function? And I'll tell you an example. If there is a diabetic patient who is, say, has with a creatinine of 2 or 3, he can have symptoms related to diabetes from the hypoglycemia, whatever, and dysesthesia from the diabetes. The patient can have low urine output and body swelling as a urinary centric symptom. And the patient can have symptoms like poor appetite, body ache, or breathlessness, so on and so forth, which are consequences of the low kidney function as complications. Try to decipher which this is. And early kidney disease has very few symptoms related to the urinary tract. Low urine output and swelling are not symptoms of early kidney disease. They come back down the line. And again, blood in the urine, which is related to any glomerular injury or any urinary tract issues, can have these symptoms. These are not symptoms of, they could be in very few subsets of early kidney disease. All of these will come only when you're in CKD stage 3, just to go back to the slide, where moderate kidney function happens. And then, of course, whatever is the cause can add to it. Now, the other way of looking at kidney disease thing is, in what stage of the kidney disease are you seeing symptoms? Like I already said, in the very early stage. When you say early and moderate, you're talking about CKD stage 1, 2, and this will be somewhere in the 3. And this is, as you go to the right of the screen, you'll see 3 to 5. I think the challenge for a group like this is, what do you do here, and what is this patient presenting with, right? Whereas in nephrology and primary care, we want to do work better on this side of the screen. But essentially, as kidney disease gets advanced, you can have problems from sodium and water retention issues. These are the face and leg swelling and heart failure, as I told you. You can have an effect of the high azotemia. That will be the loss of consciousness and drowsiness. You can have effect on the GI system. That will be the loss of oral intake. You can have effect on the bone and the skin from your mineral imbalance. Correct? So that's how the symptomatology has to be correlated to the primary effect. And of course, hypoglycemia and hyperglycemia is a very common thing that can happen in diabetics and non-diabetics, hypoglycemia. So be aware of the symptom. Now, what do nephrologists role? Yes, somebody has raised a hand.
Sorry, I just missed. What did you say the skin excoriation was due to, sir?
No,
mineral imbalance?
Yeah, that is why a big reason. Skin, cutaneous calcifications. Correct. If it's very bad, it can even lead to dermal calcification and skin necrosis. That all of us may see it very rarely, but the itching part, sometimes getting what they call nodular lesions from excessive pruritus, is something that is very troublesome for patients, right? And that is something that we may see in advanced kidney disease. And a patient like that won't have any fluid retention or edema issues at all. This patient will manifest only the calcium phosphorus issues, and the patient will have fluid issues. There'll be another patient who will have a lot of fluid retention and edema and won't have anything with the bone and the skin. It's baffling why some patients manifest, why patients manifest things differently. I think even in cardiology, you will see a low EF patient, one won't have any symptoms, and another one will be puffing and panting and presenting. Correct. You'll see low EF patients with 20% walking around. I think it's the same thing. So coming back to, okay, fine, just to walk you through kidney function symptoms at varying stages. What is the, core focus of nephrologists in CKD care is you do everything you can to delay progression, keep your creatinine stable or stabilize your GFR. And there's a lot of developments in this space. We need not spend time there. Then, of course, as the disease, as the GFR slides, you need to start focusing on complications or after effects of the low kidney function, which is listed here. Then, of course, whatever comorbidity the patient has to be managed. And then at some point, the transition, and this is what will happen in renal clinic, and then at some point, we have to move to renal replacement therapy preparation, education, and how you can do this transition in a timely manner with appropriate discussions. And this is where whether the whole challenge comes, whether people want to transit into this or they transit into this and they don't find it so um, worth it from a personal perspective, or not feasible from a family perspective, then you say you kind of don't transit it, or you transit it and I say I want to exit out of it. That's what happens. I think patients should have the choice, and we'll talk about the scenarios. So how does it map out? CKD, once they get stage to advanced stage 4 or 5, they could have dialysis, they could go into hemo, they could go into peritoneal dialysis. Transplantation, they can get it from a deceased donor. And Indian reality, very much with a lot of developments over the last 30 years, deceased donor transplant, or a live donor transplant, which can be from a related or an unrelated. Just from a general knowledge, unrelated can mean illegal and unethical. Now, that is, though it happens, I think it's it's in the periphery. Unrelated legally in India that is happening is in two forms: swap transplant, and the other one is a swap is an unrelated situation. And more related transplants are happening from ABO incompatible transplants in India. I think this is a changing space. Anybody wants to kind of clarify on what swap transplant is? Or do you understand what swap? Or maybe let me explain to you. Let us say you have a family with who the patient is blood group B, and there is no donor in the family. The donor's willing is a blood group A. There's another situation in the same town or in the city who has the exact reverse. He's a blood group A recipient and that donor is B. So you cross over the swap so that this donor gives to this recipient and the other donor gives to the other recipient. So the B goes to B and the A goes to A. But it's a transplant that happens that involves 4 people, 2 recipients and 2 donors. It's legally permissible. Now, why I'm mentioning this is I think you should have the broader landscape of options that exist for people, right? So, but anyway, what happens in India? Most of them go on dialysis. A small proportion go to have transplant. Transplantation provides 70% of the kidney function. Dialysis provides only 15% of the normal kidney function. Then off dialysis, most people in India go on to hemo. A very small proportion go on to peritoneal. Off transplants, most is live. Very few go to deceased donor. Just broad, I think, algorithmic view of what happens in India. Now, there can be debate, I mean, just from a broad knowledge, the dialysis of the hemo and the peritoneal dialysis, what is good and what's not good about each option. At a very simplistic level, we know there has not been randomized trials globally, or very few of them which have not answered the question solidly, to say that PD is better than hemo or hemo is better than PD. Very simplistic. The one subset of people where PD may work better are younger non-diabetics, where PD, and there's some advantage in the early phase and that goes away. But in a very simplistic level, both are roundabout equal from a long-term survival. What's good about hemo? Provided by professionals, I mean, in a hospital, it is kind of intermittent. It's not a daily issue. And it's quite effective in terms of, but of course, what individuals don't like is the needles, the need for surgery, interrupting. It's the only situation where you have to stop your regular life for your organs to work. In all other situations, we go about and our organs are concurrently working. So it's this interruption of life to do hemodialysis that's not great for patients. And of course, the travel issues and the indirect cost. What's good about PD, on the other hand, is it's a continuous process, and it's a very simplistic. You're using your own abdominal system for dialysis, and it's at home. And since it is a continuous daily process, it has that little bit more liberal liberties with regards to diet. What's not so good? The fact that the patient has to do it on a daily basis, and there are the effects of the glucose getting inside the system and consequences of infection and weight gain. I purposely am kind of putting the backdrop to this group so that you understand what all patients have gone past or what patients are not opting for. else it's a bit blind spot for all of you. So, okay, so you got your landscape. What happens, what is the survival issue on dialysis, and what are we talking about, or what are we trading off? I think that's key. I don't know whether any of you have had an opportunity to see a slide like this. This is data from the West, which is basically compares survival on dialysis compared to other solid organ cancers, right? It shows that it's a 5-year survival. This is talks for men, and it's actually somewhere in between pancreatic CS and other solid organ cancers. It's somewhere in between. If you take the same thing to women, is the same issue, that it's actually worse off than other certain solid organ cancers and just better off than a bunch of others. It's never seen in that relative form that how bad or how challenging kidney disease is from a survival angle. So it's not what would you say? It's quite challenging for in terms of survival for patient families, and also for the whole healthcare system to spend and actually add life to years for these patients. We in NephroPlus, since it's a large dialysis network, we've had some rudimentary data with regards to our survival of our dialysis patients. And I've just created a very simple table for you of 1 year, 2 year, 3 year, 5 year survivals in different regions of the world. And all these regions have registries where patients or entire data is captured into a single place. So you have fairly reliable data. In NephroPlus, 1 year survival is around 65%. So you say you have a 30% drop in the first year. But this includes a caveat here. All the Western data includes patients only beyond 3 months. They don't include the first 3 months data, because the first 3 month mortality is much higher, versus the NephroPlus data includes everybody, the first 3 months and the later 3 months too. So I think therefore this number is going to be skewed that way. So, but just to give you a flavor of the level of challenge. Okay, we said, okay, it's quite a challenging survival number, and you know what it is. What are the aspects that determine survival? The non-modifiable, we will step aside. The modifiable are the comorbidity issues, which I think is very important in the context of the NCD epidemics, which is what we keep seeing repeatedly in India. The comorbidity that the dialysis patient carries, it weighs down so much on survival and influences what we can do or cannot do. What is the cause of the kidney disease? Diabetic kidney disease is about 40% of all CKDs in India, and they do much poorer than non-diabetics. And the dialysis itself, there are things that we do in the dialysis unit that significantly influences survival. And lastly, there are non-medical issues, which are very pertinent. Socioeconomics, distance to the unit, and of course, compliance. Just to digress, when we looked at our data, this is yet to be published in our NephroPlus network. We did a case control design to see what are the determinants. And just to highlight in this, diabetics, patients with pre-existing heart failure, patients with dialysis catheters for a long duration, patients who were less educated, patients who were on public insurance, were individuals who had a much higher mortality risk in our NephroPlus network, and that includes an analysis of about 14,000 patients over a 4-month period when we compared all our survivors and non-survivors. These came as very strong determinants. So basically what we do in dialysis is where these are the big weighted factors: very low anemia, very low hemoglobin, catheters, and how we manage fluids, a thing that we can do in our dialysis unit. And the comorbidity is what weighs them down heavily. Now, I think there is one other aspect that is key in the real world when we try to go into advanced kidney care and when we look at palliative aspects. The additional events that add to the patient's CKD condition. There are two things. One is acute kidney injury. The other one is cardiac disease. And I'll tell you why. When you're dealing with advanced CKD, these becomes additional factors that can tilt it down, but can also potentially be treated, and it can be reversed. So when you're initially looking at an advanced CKD, you need to ensure that we are not missing these acute factors that can turn around and they are not missed in the overall diagnosis and therapy. Sridevi, I'm looking at my clock. We're at 7:30. How are we on time?
We can go till 7:55, and then few questions, and then case presentation.
Okay, fine. All right, because I need to cover Kamal's, but I had a look at his presentation, but I think maybe we'll do a shorter thing on that. I'll try to finish the scenarios. We started at 7:05, right? Okay, fine. So let's see. So I think don't miss the acute factors. One is AKI, and the other one is the whole bunch of cardiac. I don't want to dwell on all the combos, but there's a whole bunch of ways how this toxic combination of cardiorenal, where it's a bad heart that affects the kidney, or renal cardiac morbidity where bad kidneys start affecting the heart. But essentially, when you're looking at a patient, you need to explore the question on advanced CKD, are there superadded acute kidney injury factors, and how is the heart doing, right? And now we'll go into the scenarios. I'll get you the first scenario. All of them are real life that I took care of, so this thing. I don't want to cross the bridge again. And the scenario is actually an elderly gentleman whom I took care of, who lived with his son and daughter-in-law. And very strangely, all family conversation has always happened with the daughter-in-law, who was extremely caring, and the son was supportive, but then I don't think at any point he was in for the intense conversation that we had to have. And his healthcare expenditure was mostly paid for by the family. And what happened in his case was, when I first took care of him, he came in with a heart failure, fluid overload, and he underwent dialysis for 2 weeks, and he came out of that severe fluid overload situation. He was hospitalized for a couple of weeks, but then his kidney he came out of the severe renal failure and fluid overload. What behind that, he was somebody who was in his body weight was somewhere in the 35-40 kilogram range, a very frail individual, and he had a little bit of a disability on one of his arms. That was from his childhood times. So he came out of this dialysis stabilized with background creatinine of 5 or so. You go back to the CKD staging, he'd been a CKD 3-4. So the conversation was, yes, you came out of the dialysis. Right now, he was compensated in a CKD 4, but we said, you might need long-term dialysis. Sometime later, can we look at an AV fistula, preparation for renal replacement? And he says, I don't want dialysis, doctor. I know what it is. I know I survived this. I don't want it. The daughter-in-law's question was, what will happen, doctor, if he needs, and we know we went through it, we know what dialysis is, but we are sort of caught in between. Why can't we still go ahead with the fistula and get him prepared, right? So very often, in alternate, when the next case we talk is somebody who's got these ideas of what dialysis is, and they will see only the thumbs down issues of dialysis, the hassle of coming, the cost, the pain, and so on and so forth. This was somebody who had gone through it, got the benefit of it. So he was actually making a much better informed decision. What will happen is, I think in this patient, from his situation, we could kind of predict that this is somebody who will have the fluid related issues manifested. He could have anemia issues because he was already having it, and that could be something that could be treated and to make him feel better. And we had to tell them that, he could come up with other things which he was not showing up at that time when he came out with the acute kidney renal failure. But he could come up with this. And then over the subsequent clinic visits, though he did not want to have the fistula and the dialysis, his creatinine has crept up from 5 to 6 to 7, and I continue to see him in clinic. And we're still focusing on the skin symptoms and the sleeplessness symptoms. His fluid buildup has never happened again. Quite surprisingly, I anticipated he would go on dialysis in about 3 to 4 months. It's 9 months later. He's never had another heart failure. His GFR has dropped to the 10s from the 15s or even lower. We've been able to effectively manage his anemia. So he's remained symptom-free, and he started showing the skin symptoms and the sleeplessness. When we talk about questions, we'll talk about specific drug interventions for skin issues and also bone pain issues. So I think that's how this case was. So again, re-emphasizing, you look at sodium water issues, you look at blood pressure, and I think hemoglobin, I'll again and again emphasize that something is that causes symptoms nearly as equal to azotemia, and it's very hard to decipher which is azotemia and which is anemia. We should get very comfortable in treating anemia and the other supplementary interventions for anemia for improving quality of life. Bone disease, we can take questions later. So this was somebody who had sort of gone through it. So I don't want to go through it, but in a different context. If you want it short term, yes, I survive, but long term, no. So this was one scenario, right? So the other scenario was very different. Somebody whom I got involved with is advanced COVID and a creatinine of 4. A businessman who had enjoyed his alcohol in his jolly days, but now he was cared for by the son who lived in Chennai and an expanded family, typically who are all around the world. And I got to see them at a different stage, but the background just for us to know. He carried a lot of comorbidity. He had a documented CLD from his alcohol, but well compensated. I picked him up when he had a long COVID and his creatinine was in the 4.5. He progressively had weight loss, and all his clinic visit was his home helper and his daughter and his son would come once in a while. His creatinine was creeping, 4.55. His GFR was none. He never wanted to go on dialysis. He said, "Doc, I've had a good life. COVID was bad and it went through hell through COVID." I said, "I really don't want to go on dialysis." We said, okay. So, this was not somebody, here was somebody who had not experienced dialysis, but who did not had negative perceptions of it. Ethically, we kept off. And strangely, with very advanced stage, he kind of changed. I said, when he became symptomatic, he said, "I'll go on dialysis." And then we started him. We had to start him through a catheter. Quickly after that, he started having low-grade fever, and he started showing mediastinal lymphadenopathy. It landed out to be a TB diagnosis, lymph node TB from steroids treated from the reactivation of TB from past steroid treatment for COVID. So now we got comorbid. 4 weeks after start, all his children came by. We had the conversation that he's sliding down, and 8 weeks later, another 4 weeks later, the catheter infection he didn't come out of. His health status dwindled. But this family opted to keep him in the hospital for supportive care. And this case highlights the very important thing that was learned from a very simple observational study from the West, where if you took elderly people, this is the typical case scenario, right? Elderly, most of them diabetics, most of them with heart failure, and you started them on dialysis, and you saw what happened to them at 3 months, 6 months, 9 months, 1 year, even with the best of care, 30%, it goes up to 50%, it goes up to 65, it goes up to nearly 75. If you're an elderly comorbid with heart failure and significant comorbidities, this is what happens to you, that large proportion die. But I think what is striking, also well illustrated with this gentleman, is how the proportion who have good functional status significantly drops. The functional status maintained drops. So in a nutshell, you have high mortality and dropping functional status. That's what happens when you start very elderly diabetics and people with comorbid on dialysis. So it's quite a challenging one, and he illustrated all of that. Though technology could give him the acute survival, I think his long-term quality of life was very poor between his respiratory and his renal. So we just did symptomatic care purely for his respiratory distress, and family wanted this basic nutritional care. So he's in the ICU initially, and then we kept him in the room. And he went from no dialysis, a trial of dialysis, then he went to the path of the comorbid dialysis patient, and then we stepped back, and the family did not want to continue dialysis, and he was on dialysis practically for 8 weeks, and we withdrew. The third case is a very similar one, a very different one. This was somebody who presented post-COVID to our oncology department with advanced bladder cancer, and she had a creatinine of 6, and we got involved at that point. The first thing always in oncology, because of bladder cancer, she didn't have any obstruction. And when we looked through her records, she had a documented renal function of 1.4 about two weeks ago, done as part of it. And she presented with kidney failure and volume overload complications. Here again, the question of an acute or a chronic comes, right? So this appeared like, the story appeared like an acute. So, we told the family, and we said, we need to, let us initiate dialysis, and we have to, there might be some chronic component, but there is an acute component. That's what we believed. And we dialyzed her. And her weight dropped by 20 kilos. She had that much of fluid in her system. She got better from the dyspnea and so on, but at no point could we get her to looking at her kidneys to see whether it had a potential to recover. Initially it was the fluid and edema, and then though we got out of it, we still could not diagnose. Kidney did not improve in the next 2 to 4 weeks. We went ahead and said that there was a drug exposure history that could have caused an interstitial nephritis. We gave a short course of steroids. Still, the kidneys didn't open up. And she said, I don't want to continue it. She opted to withdraw dialysis. She wanted to be at home. And the son, who was a caregiver, would periodically visit the hospital, discuss symptoms, issues. And in her case, the symptoms were appetite loss, skin symptoms, and joint symptoms. She did not develop so much of the volume symptoms. And this was early COVID days. Our online consults and other home-based interventions were not well tuned. But I think if you ask me now, I think online viewing of patients and having assessment is more of a reality, and that's something that I guess we can do better. And this is the typical kidney disease palliative care scenarios that we see a lot in the context where I practice. I practice in a mid-range hospital in Chennai. The choice restricted is something that I will come into when I cover Kamal's talk. Choice restricted meaning patients don't have a choice because more overwhelmingly from economic reasons. And I think I'm saying it is getting postponed because now patients can enter dialysis even if not affordable through public insurance. So they may not opt for dialysis just because they don't afford. They get on it, indirect costs on dialysis break up. So they might look at avoiding dialysis at a more later stage. This is the cluster you should look for: a dialysis need in an elderly with comorbidity. That cluster is bad news, and how we handle it is what we all need to learn together. Symptom management can be variable. Try to differentiate: am I dealing with the fluid? Am I dealing with skin and bones from this thing? Am I dealing with the comorbidity? And try to differentiate which we need to focus on, and that's the point. And I think nephrologists in general need to step up in this space. I think we don't have adequate training in this space, and we since it's an intervention that we control to a significant degree as part of our practice, few nephrologists step up and say, hey, let it not be offered. Let's step back and offer pharmacological therapy and not the interventional dialytic therapy. Shreedevi, let me stop here. I can cover briefly Kamal's talk. I can go quickly. Do you want me to do that, or shall we take questions?
Yeah, sure. You can just, it will be good to hear what he has to say.
Yeah. No, but any broad questions around my topic before we go?
Yeah, there are a few questions. From Dr. Punita. She's asking about a few challenges that she faces.
Sure.
First, she's mentioning about intractable hypernatremia. Couldn't treat before a diabetic food debridement could be done. So lost the patient in sepsis is one question.
I'm looking at
Intractable
it.
hiccups.
Okay, let me maybe take that. You know,
Sure.
hypernatremia, and this is Dr. Punitavati, right? You know, hypernatremia, I'm quite surprised why that has happened. I think very simple way of telling to this group is, if you're seeing hypernatremia, please think of a glass of water, which has too much salt and too little water, right? So you just need pour more water into that glass. And that means it is about using fluids that have less sodium. It's a half normal saline or a dextrose. Maybe offline later, if you share my email with her, maybe I can guide her, how you do rule of the thumb fluid managements for hypernatremia. It's actually fluid, and this is a typical one where you can reverse and actually see visible patient improvement and not lose a patient from it, but then the sepsis management. Intractable hiccups, the one common message to this group is, please do not use baclofen in CKD patients. You will see horrendous alternation. It will knock them out and you will see patients in coma in 2 days. The worst ones will get there. So just keep away from baclofen. Your interventions are still left to all the other outside baclofen issues, from PPIs to antiemetics. But again, this is one of those things that can make life quite horrendous for patients until they go on renal dialysis, and post that they settle down. If you're dealing with a CKD stage 5, 4 or 5 situations, and typically it happens only in that 4 or 5 situation. It doesn't happen in CKD 3. Anorexia, poor intake. I think here what happens is, very often with patients we talk, if you have replacement on board, that intervention helps them address some of these factors. If you don't have, your pharmaceutical interventions or drug interventions are pretty much the same as for anybody within PPIs and any antiemetics. Second thing is, there is no major dosing adjustments. Third thing is the tussle that we always see in the clinic, trying to be diet restrictive on somebody who's having anorexia and poor intake. I think we need to go away from that and say the patient is having so little intake, his natural disease is driving his thing down, and they will have a taste for certain food contents. And I tell families that when there is a natural switch off system, there is no point we again restricting. So whatever he or she likes, just give him the liberty, right? That's where it goes. So you need to know if you're on a replacement mode and a time limited trial. In that case, better dialysis can actually adjust these anorexic symptoms. If you're a non-dialytic, the standard pharmaceutical therapy, and I think you should not have any food restrictions, just from a quality of life perspective. How do we treat diabetic and CKD patients not responding to gabapentin or pregabalin or duloxetine? Can you start morphine from a neuropathic management? Yes. In pregabalin 2, one caveat: don't start at a dose at the 75 milligram dose that you might start for more advanced CKD. Start at half that dose. There are preparations in the market now. You may want to look for at 37.5 milligrams and even 25 milligrams. The other way is to do them 75 milligrams on alternate days, which is what the Western guidelines say. That is one caveat. The other thing is morphine. You can try again, start at lower dose. And this neuropathy in diabetic and in the DKD patients can partly be diabetic and partly be azotemia related. It's very hard at a clinical level to differentiate it. But in an advanced CKD 4 or 5, you might be surprised sometimes when they go on dialysis how some of the neuropathic symptoms, particularly the motor neuropathies, may improve. That's the only other thing. So, okay, I don't see anything else. Just to quickly go over Kamal's slides, right? Kamal, as Sridevi already said, writes a blog, and not only that, Kamal was on a global group that discussed this whole conservative care for advanced CKD for low middle income countries. Sridevi, maybe I can share that paper with you. I think you could share it with this group. It was published.
Yes.
Just send me a mail. I'll share that particular publication. There was a global meeting back in 2015 or 16, and Kamal was part of that group as thought leader for kidney patients, and also, it was a combined group between nephrologists, nephrology nurses, and also a patient, and Kamal was representing that group. And Kamal had synthesized that output into this talk, and some of these were his own personal views. And for the group, as has been already been told, Kamal has been on dialysis for 25 years, and he's quite an active guy. So, it starts with his own personal views about how he wants to see his end if it is to happen. So outside that, I think the evolved reality in the West, not yet in India, is this whole thing of conservative care, where when you're an advanced CKD stage 3 or 4, you don't limit the option to dialysis and transplant, like my presentation said. There is another option which is symptom-based, and that is comprehensive conservative care. Now, the broad thing in India is the legal framework, the clinical guidelines, clinicians training, I'm meaning nephrologist training, nephrology practices training, and definitely to say the cultural aspects and unfamiliarity of patients. Because, and in India, the thing is, if you say the option exists, families have a tremendous amount of guilt if that option that exists is not offered. So I think we have multiple aspects in saying, okay, let us not, transplant is not a transplant candidate. Dialysis is there. The patient doesn't want, or we cannot afford, and it is not feasible because of distance whatsoever. Let us try what to do next, right? So I think we have several areas to cover in the Indian context. And so and not just in India and LMICs, so this remains still an area of uncertainty. So one of the things that they spoke in the group was to build that awareness and bring conservative care as another option on the table, and for everybody to say that this is not about giving up, but keeping it as an option on the table. And the way to think is, I spoke about CKD and AKI, is to say when you go to end-stage disease treatment, why this thing is done is, though these are options, you can go from anything to anything, but also keep conservative care as an option. And also the fact that you could say, I don't want, and then at any point decide. And also I think there should be other way that you're on, I don't think this is working, I just want to go to conservative care, like the cases I have spoken. But keep this as something that is, and this sort of gives the flow path of how it may work for patients. And this is the broad categories that they said. That is, an elderly comorbid patients, it says, okay, I have comprehensive conservative care is what I want to do. I don't want to do anything else. The scenario that I spoke as case number 1 is exactly this. I know it, my family can afford it, but I don't want to go through it. And the case number 1 I presented, already experienced what dialysis is. So it's actually a very solid case that he was making, that I want conservative. The choice restricted care is what we talk about, that when resource constraints prevent or limit access to kidney therapy. In the Indian context of all patients who need dialysis, the large proportion is actually in this group. And that quantum of the group is actually coming down because of public insurance. Numerous state level insurance, the Prime Minister Jana Yojana, the PMJY, all of them are kind of making this, addressing this gap. So that's changing, but they may enter, and whether they can sustain or not is a different challenge. So then there is a whole other bunch where CKD is not recognized. We need not delve into that. I think these are the two things that we need to go off. And this is exactly what I mentioned, that was discussed in the group. Like one of the slides that showed, in old individuals with major comorbidity, dialysis doesn't seem to give net survival or quality of life benefit. So this is clearly a solid case to talk of conservative care and actually explore it. And this is the kind of patient that I showed in case number 2, correct? Frail, fatigue, and treatment burden was high. He was not demented, he was conscious, correct? So this is the one that, and this is the affordability and access groups that is gradually getting redefined in India. But this is a reality in all LMICs. Now, if you want to get into this space of saying, well, can we offer choice of conservative care? The nephrologist plays a leadership role in this. This is absolutely kind of a blind spot, or what you say, an undefined space in India. We don't have them in the dialogue table at this time. This is what the group felt that we need to build. But the space here, the patient and the family, when the nephrologist is conversing, is quite, from my own personal experience, it's quite a mayhem. Families want one thing, the patient want one thing, and there's always a tug of war. And interactions are quite intense and also confrontational, and families feeling dejected when the patient wants to pull. And I, as a nephrologist, I have very clear views that just go by what patient's choice and ethics. But very often I see my fraternity not being as well directed with decision making. The other wishful thing out of the global group was that we need to protocolize it and build documentation about it, and also bring other people into the conversation, right? Palliative care nurses and technicians, and in the nephrology space, we don't have anybody there. And of course, build other support system and structures. Like in the patients that the case number 3 who was at home, who passed away, we didn't have any of them playing. The son was coming back to me, and I was the only one who was kind of whom he was talking to with his mother's care. And I struggle with no other person to work with me on other softer aspects. And I think this is something that has to change in the LMICs. The ideal approach is whether we can use technology and other stakeholders in the system to do some technology-based interactions for symptom assessments and appetite and health assessment, supplemented by some kind of face-to-face interaction and less periodic interaction with the nephrologist. Is this possible? I think yes. I think the Q&A sessions may kind of throw up scenarios that you guys have already done. It'll be nice to learn. And the shared decision making, as much as it's stated, I think in real life I find it very difficult because in India, patients try hard to make their own decisions, overriding their own family members. And this part, if we are able to bring a consensus that test, treatment, and care plans can be built, meaning what frequency you do the test. A reasonable thing for this group is somebody in a CKD stage 4 or 5, do your creatinines at 2 weeks apart is the best. Keep an eye on your hemoglobin at 2 to 4 weeks, because that is an intervention that is very much feasible. Fluid issues, you can adjust your diuretics and make them feel better. And expected survival at very advanced CKD5 with fluid-related complications is probably a couple of weeks, 2 to 4 weeks. If they don't have those fluid-related complications, if it's just bone and hemoglobin, it can stretch to weeks. And the tests, as I told you, creatine, potassium every 2 weeks, hemoglobin definitely every 2 to 4 weeks, parathyroid hormone at least at some point, and then subsequent intervals will be determined based on patient symptoms. Advanced directive, again, I think we should take it in the Q&A, but I'd like to hear from you guys. But if this comes into reality in the future, it'll really help dialysis initiation or not initiating dialysis in a great way. The other, I think this is something that I told Kamal that we should put forth to the group, that there are health system aspects in India that add to it. A lot of private sector where care is sought for. And I think there's definitely a trend of, even among the medical fraternity, of medicalizing aging. There is this perceived issue about litigation, which I think is not as much once you have open conversation. And I don't think we have clarity on how these things should be documented. In public hospitals is even more difficult. And the trust factor is between the doctor and the patient is something that is broken. And of course, the payers, be it the private insurer or the public insurer, they're not aware, or they've not even brought it to something that they can pay for, which will actually help patients and families who opt for this kind of care. So I think every stakeholder in the health system has not thought of this space at all. So I think the way to move forward is for all of us to push this agenda. Let me stop there and let us take questions or move to the Q&A, whichever way you want to do. Has my screens, have I stopped sharing?
Yeah.
Yeah,
So
okay.
there are a few questions in the chat. We can quickly take them up before the case presentation.
Sure. No issues. Okay, that means a good idea about, okay, wait, how do we treat diabetic? Okay, it's good input about food restrictions, sir, thanks to, but most family members are already imposing too many food on the one CKD search, but when to relax the restriction is what is clear. I think the answer to that is, I think if you have a definitive kidney replacement therapy plan, then you know there is a goal to achieve. And then you kind of think of the 3 Ds, the diet, drugs, and dialysis. So I think I think if the dialysis care plan is getting more defined and acceptable, and you know it can be implementable, then the food has to work along. If you're not going to do that, correct, and if you have a patient who doesn't have too much of the salt and fluid issue, I think you should be more liberal with food, because a lot of your food challenge comes in the potassium, salt, and water. That's when it gets very kind of imposing on the patients. Now, the other way you can do it is, may sound crude, is actually be liberal, meaning, okay, fine, let loose. Patients go down that path and they experience a jolt, a hospitalization with a little bit of fluid excess, or a hyperkalemia, semi-emergency, the two. And then they kind of, it's like burning your hands, right? And then they pull back, right? And everybody understands. That is another way of doing it. Else, I think what happens is the patients hates it, and it's just, nobody's happy. The patient is not happy, the family is happy, you just are this person driving it. Starting dose of morphine in CKD patients. Sheila Rathod, what is that you have done, or can you come on and say what your experience, and I'll tell you, and what is the
good evening, sir.
Yeah, Sheila, tell me.
Uh,
Go ahead. Can you tell me the
I have not
context and then say Tell me.
No, I've not started morphine. Like one of my diabetic patient who is CKD and who has a low ejection fraction. He
Okay.
complains of severe burning feet and pain, not settling with pregabalin. I've tried pregabalin, I've tried nortriptyline, I've tried gabapentin, I've tried even duloxetine. But on and off, his only complaint is I have a lot of pain, doctor. I have a lot of burning sensation. My pair literally burns. So I thought I'll just start him on morphine.
You are. I think you should. And how? What is the age of the patient and how heavy is this patient?
So he's 66 years old and he's, 66 is his weight and he's 72 years old.
It's reasonably well. And in your practice, what are the range of doses that you will get? In your practice, what is the range of doses of morphine that you'll have access to?
No, actually I'm a general practitioner, so I don't have access to morphine. I will be prescribing him actually.
Yeah, but then wherever he's going to get, right? So that's why I'm asking. If you can get the because with the oncologists I practice, the way they use morphine is they are at 10 mg, but then they're using it in a different context, correct? And they do 5 and 10 mg. I think you should start at the lowest dose if you can get at a 5 mg level and see how his tolerance is. And then that's why I said why the body weight and this thing is the body weight and the age. The body weight is always body weight, creatinine, and the patient is how you envision where your GFR is, right? And I would strongly recommend use apps to just think in a GFR way, correct? A creatinine 2.5 in a 75-year-old lady who is just 40 kilos and sitting in front of you would mean a GFR in the 10s or 20s, under 20. The same thing in another well-built 65-year-old male will mean a GFR of 35, 40. It's a very significant, and therefore which will influence how your drug kinetics and your consequences thereof will be. Correct. So which is why when you think CKD, think 3 parameters, right? Body weight, age, creatinine. Just so that will tell you where you are hovering on the GFR level. And then that will influence your drug dosing titration. Then becomes individual response, right? So in a case like this, you should at least try it at on a 5 mg and then titrate it upwards. That's what I would do.
And then that we can continue as long as required.
Yes, I mean that's what I'm saying, right? If it depends, right? If you think there is a renal replace, this DKD neuropathy, what is the creatinine of this patient?
So his creatinine remains around 2.4, 2.5. His GFR remains around.
So he's not in the advanced CKD where there is a neuropathy from and a dialytic intervention.
Yeah, no dialysis. He's just on insulin and
he's not there. Yeah. So then you'll just have to try and see, where you balance off between his morphine tolerance and his symptom. Somebody has how much is the survival in conservative care as compared to being on HD? Families will ask. If you are looking at the very early data coming for a subset, which is the elderly comorbid group, that's where there's enough people who have gone on conservative and there is some comparable data on HD, appears very compelling, right? Meaning you could safely say if this question pertains to this an elderly patient who's frail, who has a lot of cardiac or other comorbidities, it's fair to say they roundabout survive to an equal duration, right? Which is usually in terms of months. But if this same CKD patient has a lot of fluid retention issues, then you could say it will be practically a matter of weeks, because patients who have salt and water retention tend to have more mortality morbidity in the short term. Understand there can be patients on very advanced low GFR state, CKD 4, 5, even on dialysis, who don't manifest much of salt and water retention symptoms at all. And they'll be typically the non-diabetic CKDs. They'll be fine. They won't have any fluid issues at all. They won't get into too much potassium issues. So they'll actually go longer survival. So I think that is the clinical differentiator they have to keep. Fluid and salt will be in weeks. If it's not, it can be in months. If a patient is on dialysis, decides to go for comprehensive cancer, how much how do you manage this? How to manage such patients? I think the key question is when they want to go conservative care, they
So I think you answered the question, sir. Subsequently
okay.
after I.
Okay, good. All right. So can we go on to the case presentation?
Yes, we
okay,
can.
Okay, go ahead.
Dr. Megha, you have the network.
If she doesn't, or she can just put the slide and we can she can move.
Yeah, Dr. Megha, are you there?
Yeah, I'm there. Hello.
Go ahead.
Hello, everyone.
Yeah, please go.
Good evening, everyone. I'm Dr. Megha. I'm a physician. I'm practicing in Ranchi right now. I'm from Kerala. My patient was a 58-year-old female. Her diagnosis was chronic kidney disease in stage 5 on thrice weekly HD. She had coronary artery disease, triple vessel disease. She's a diabetic, hypertensive. There was amputation of second toe and third toe right foot done a couple of years back. And she has diabetic retinopathy. Presenting complaints were fatigue, loss of appetite, loss of sleep, waking up from sleep due to feeling of breathlessness. It was more of feeling of breathlessness. Yeah, it's okay. History of present illness, already mentioned that she's on thrice weekly dialysis. She presented with inability to sleep at night. She wakes up with the feeling of breathlessness, sweating and palpitations, relieved immediately after waking up actually. No history of chest pain, history of loss of appetite and fatigue present for a few months. Her main concerns were loss of sleep and breathlessness at night. On examination, she was anxious, fearful, conscious oriented. Her temperature was normal, vital signs, pulse rate of 86 per minute regular, respiratory rate of 22, blood pressure 150/80. She had anemia, no edema, JVP was not raised. Basically, there was no signs of fluid overload whenever she presented with this breathlessness. Chest no, yeah. On her investigation reports, hemoglobin was 9, creatinine was 6, her LFTs were within normal range, her potassium and sodium normal. Her CAG was done last year and triple vessel disease was diagnosed. Good EF and CABG was advised, but patient was not willing on medical management and thrice weekly hemodialysis. So since she has good EF, even the triple vessel disease diagnosis does not really explain her breathlessness. She is a 58-year-old married lady. That's a psychosocial aspect, living with her family. She was a school teacher, stopped working 8 years back. Husband is a retired bank manager. She has 3 daughters. 2 are married and employed in different cities, not providing regular financial support to parents. Youngest daughter is 27 years old and is working in a private bank in the same city. She's not married. They had some property which they sold and the deposit to the money in the bank. This money and the other savings are being used for treatment and daily expenses. Need more money for younger daughter's wedding. She's not willing for CABG and is paying for fewer hospitalizations so that she can save money. Her medication, the long list of medications include, she's on insulin, she's on linagliptin, blood pressure, amlodipine, and pregabalin. She's on alternate day pregabalin 75. She's on calcium supplements, febuxostat, atorvastatin, clopidogrel, ecospirin, and there's weekly erythropoietin injections and thrice weekly dialysis. Her main concern is loss of sleep. It would look like more, we could really never find, there were multiple admissions with, again, same complaint of waking up from sleep with breathlessness, but there was never signs of fluid overload. And again, EF was always normal. Her main concern was loss of sleep and how she's going to finance her treatment, because she was doing, she was continuing so far well. She's a 58-year-old lady, so thrice weekly diet, she was doing well otherwise. Her lifespan, because one daughter is not married, she was worried about that more. So these were her main concerns. In summary, she was a 58-year-old female, chronic kidney disease, stage 5 on thrice weekly HD, coronary artery disease, triple vessel disease, DM, hypertension, status post amputation, and then diabetic retinopathy presented with insomnia, and clinically it was more like panic attacks rather than fluid overload, because these episodes would happen even on the immediate same day of when she did her dialysis, or even the next day, and hospital was nearby, so she would come immediately and it would settle before anything. She was not able to sleep. It was not really we were not sure whether the breathlessness could be settled. We didn't have to give any diuretic or anything, actually. It would settle on its own also. She couldn't sleep. How can we support this patient? Will more frequent HT help? Because we didn't see much fluid overload, but psychologically she had become used to the whole 3-weekly HT, that she would wonder, should I increase the hemodialysis frequency so that this wouldn't happen? Should we try and convince her to reconsider CABG? Again, her EF was good, so she was not in active failure ever. But again, according to the triple vessel disease, after the cardiologist did advise CABG, then will a consultation with the psychiatrist be helpful? And another, should we look into other causes of breathlessness, as there are no clinical evidence of fluid overload? Thank you.
Can you just leave the questions on? So Sridevi, how does it work? Like, you want me to do some comments, and I'll maybe I can.
What?
Yeah, I think.
I think I can maybe help you addressing the HD dimension of it and the comorbidity. The non-HD, I'll give my personal comments. One, what was your name?
Megha.
Okay, Megha. I think this is so chillingly similar to a patient I'm actually handling in my own practice. So I guess, it's reassuring that, okay, fine, the same thing. So coming back, see, the thing to approach breathlessness in a dialysis patient is dichotomize. Is it something that you can do at dialysis, or it's something outside dialysis? Dialysis related will typically be so cyclical, meaning it will happen more closer to the next dialysis. And one of the three has to be there, right? You should have excessive fluid gain, so which can be determined by the weight gain, weight loss pattern of this patient on dialysis and between dialysis, looking at that records. If that weight gain, weight loss is less than 6-7% of the patient's body weight, it means that the patient is controlling the intake and adequate fluid has been removed. So, you can sort of nudge that out as a dialysis-related dyspnea. Dialysis-related causes, you should look at hemoglobin, blood pressure control, and of course the weight gain, volume-related. You would want to just look at how the blood pressure pattern is for this patient. And hemoglobin is 9 is reasonably good. So it does not appear to be a dialysis-related, and thrice weekly, you look at the patient's general urine output. And I would say more frequent dialysis won't be an intervention that will be of help to this patient.
Exactly. So she was satisfactorily dry, actually.
Yeah, I think we will be going down the wrong path. Now, the CABG is an interesting question, and I would, if I was managing, I said I wouldn't push hard for it. I think we should look at Japan to really see the data, how good medical management of CAG actually happens. And I think, whenever in clinical practice, I've learned one thing, right? You give a decision you say you recommend an intervention, and the patient takes the opposite path. This is what, you recommended CABG and she's gone the opposite path. And the last 1-year course is the control arm of a randomized trial that she's shown herself, right? If she's had no ischemia, she's had no heart failure, despite being on advanced CKD, she's told you as she's on the control arm of the RCT and she's doing fine. So there's no reason to put over CABG. It doesn't help her sense of anxiety about the financial burden of it and whatever other life responsibilities. So I would take the opposite route. You're doing fine without not opting for CABG, and actually may alleviate her anxiety. Her anxiety could be driven by the fact, do I need CABG? Is my life at risk because I'm on CABG? Therefore, I have anxiety and I want to see my daughter's life. I want to also save money. Actually telling her you're doing fine, your cardiac disease, you don't have any cardiac disease. In fact, you're doing fine on medical therapy and there's no need for your CABG, will actually might be reassuring. That's what I would do. The third only other caveat that we may be organically missing is arrhythmias. She having any paroxysmal arrhythmias is the only thing that is not captured in this. Maybe doing that is the only thing, but it's, but it's so, so typical in the night, and this thing makes that, why it should happen only in the night or not random. Somebody who's arrhythmia prone will typically show it up intradialytically and not just paroxysming only in the night. So I think, I mean, just organic cause, that's the only other thing that I would think of, being so paroxysmal, creating the kind of symptoms that she has. But the typical night ones and only at that time makes that, that's a counterpoint. The psychiatrist and the anxiety, in my experience, actually for this patient whom I did all of that, and she actually reverted and kind of gave a shelling to her husband, saying, you think I'm mad, I'm not going to go talk to anybody. The path is closed. So HD, no. I would think she's done very well for herself on medical management for CABG, so I wouldn't push it. Other clinical evidence for dyspnea, nothing is going to come paroxysmal other than an arrhythmia and go away. I think no self-respecting pulmonary embolism or any other cause is just going to come back. And the fact that you've done no intervention, she's gotten better, shuts that door. Arrhythmia is the only thing. Psychiatrist or counseling maybe.
During one of the admissions, actually in ICU, we didn't do a formal halter, but we can record in our monitor. So there was nothing, but she still had those attacks. So I did show the psychiatrist eventually. The anxiety medicine actually helped her. She's a little better. So I think
telling her that you don't need CABG might actually help her, because she might be living in the fear that, hey, I need it, I'm not doing.
Exactly.
Maybe she wants to see her daughter's wedding, so she has that anxiety. Will I miss that out? That kind of can be driving anxiety, and also how the financial balance can be driving anxiety. That's how I would see it. She's done very well.
She's a teacher, no, sir. The repeated questioning of PND and orthopnea, she's also really worried whether, when you sleep at night and wake up with breathlessness is supposed to be hard. She's also reached the point where she's wondering whether it's hard. So telling her, doing the halter and ECG continuous was basically to tell her you're fine now. Yes, theoretically you need CABG, but if you don't want to do it, let's wait. She has no ischemia.
Yeah. See, there's another a broad message to this group. Stress test, right? The cardiac. Every dialysis is actually a stress test, meaning you're just rocking the hemodynamic system of the body. And there's so much of fluid shifts and your heart has to adjust to. And if she, with her good EF, whatever recommendation was done, if she's gone through this many stress tests of thrice weekly dialysis for 1 year, and she's never developed intradialytic chest pain, she's actually doing well on the stress test. So you should say, even during dialysis you're not having, you should be more dogmatic that you're okay with medical management.
Yeah, even in ICU, we've done dialysis.
Tell the group. This is not somebody who's CKD4 staying at home and not having chest pain despite advanced CABG. Exactly. This is somebody who's on thrice weekly dialysis, and somebody who's got critical amount of coronary disease. If they start having intradialytic chest pain, now that is a headache. That is something that you have to push. If she hasn't, I wouldn't even bother. So, you're fine. You just do an optimize your medical management. The other thing other cardiologists do, depending on which cardiology practice you work with, is using all your second line drugs for anti-ischemic therapy, right? Your trimetazidine and nicurandil. I know among two groups of cardiology, some of them, because trimetazidine is kind of a European drug, and the Americans are not, from the global evidence that you see. I think that's another drug that, sometimes maybe it says, oh, there's an additional drug, I'm feeling better. If it helps her head, I would. Because on the drug list, I didn't see, and there is no reason why CKD5 patients should not get trimetazidine.
She never went back to the cardiologist after the CABG, sir, and she's still with me. And she's not willing to even consider that, sir. She's really not willing in the mood to consider that.
Yeah, fair enough. Fair enough. She doesn't want to get into feeling cornered with the cardiologist, right? Hey, you need a CABG kind of a thing. Whereas we can be, as a, with a nephrology colleague, you add these drugs. I think you're doing fine. And tell her that on dialysis sessions are fine. That means your heart is doing fine, so you don't need to worry. That's how I would put it across. Address that anxiety. That's what I would do. Definitely, if it's one of my patients, I wouldn't get bothered with CABG. You're doing fine. Your dialysis is going fine. Work on the soft, on the anxiety part, and take it there.
Right. Nowadays, we admit her to the ward, sir. She's better. She's better. So less admissions. Now, last 2 months, she's okay. She's not come. But, it reaches a point, if she goes anywhere else, she'll go to the ICU. Exactly. But, if she's coming to the same place, she knows she'll be there in ward one day, and then I'll send her the next day. So
And it also depends on who's on call in the emergency room that night.
Yeah. So a lot of Yeah, but if it's in the, they usually, they know it's to ward. So yeah, now even if somebody asks for a consent, the family is okay signing the consent, I'll keep in ward. So that's the
What
point
is
where it's
your
reached.
background? What is your background, Megha?
I'm a physician, sir. I'm a physician. I was in
Fantastic.
medical
The way you
college in
presented
South.
the case is absolutely fantastic. You
Thank you so much.
pulled it out. I think Sridevi, I think it's so brilliant. You kind of have teased out every micro aspect and the right questions. So I can tell you, I wouldn't, for me always, if your sessions are stable for somebody with cardiac, your heart is okay. It could be a heart failure patient, it could be a low EF patient, it could be a CAD patient. Your heart is not bothering you on dialysis, and it doesn't make you run to the hospital for any unplanned healthcare need. I think we can work with whatever cardiac therapy you're on. That's a fundamental message.
Okay. Thank you so much, sir. Thank you.
Thank you.
There is another question in the chat.
Okay, let me look at it.
Management of insomnia and hiccups in CKD.
Research. Okay, let me go down. She's educated to explain medical management, insomnia, pruritus, and hiccups. Okay, medical. Okay, in CKD again. Let us take. Let's leave the dialysis part out of view. I think hiccups. I think I covered previously in the question. Pruritus. I think the thing that you have to look is in CKD patients, make sure your mineral balance is addressed. When I say mineral balance, definitely see in CKD stage 3, 4, have a view of your calcium, phosphorus, and intact parathyroid levels. If your phosphorus is higher, make sure it is it's controlled. Be familiar with phosphate binders. In general, I think the practice is to use calcium or what is sevelamer hydrochloride or sevelamer carbonate. Preparations are there in the market at much lower prices. They used to be in 20, 30 rupees. Now it's in the 7 to 10 rupees. So I think that is one intervention. Check your intact parathyroids. Try to keep them in the 140 range. Drugs to push them down are active vitamin D3 comes at 0.25 microgram tablets. The higher the PTH, the higher level you might want to use. You may want to use at 0.5 to 1 micrograms per day. More if your PTH is really high, above 1,000, which it's not uncommon to see. You might want to use a drug called cinacalcet. That's the chemical name. It comes as 15 milligrams and 30 milligram tablets. It's once or twice a day. I think that is a very fundamental thing you need to look at. Pruritus is a cause of pruritus in this patient. Symptomatic, what our nephrology textbook always talk about, the next level is hydroxyzine, comes as Atrax. Then the next level is pregabalin. If it's above and beyond that, more advanced CKD, dialysis becomes a necessity. What is the other thing on pruritus? Insomnia. What is the third symptoms that this question had? Hiccups we covered. Insomnia, always look for secondary causes, and again, whether there's any cardiac issues, whether there is symptomatology like skin and bone issues. If ain't there, then you get into sedatives. Sedatives have variable effects. Some of my patients, I have tried melatonin. It seems to have it's much. I find it easy without the runoff effect. Sometimes pregabalin has its dual thing if it covers the skin and the itching, but the response is so different. There will be one patient on a 37.5 who will go knocked out, and on 75 they won't get it. But I generally would start at a lower dose. It gives a dual benefit. The pruritus in this thing, and I think it's a wonder drug. Yeah, but response is very variable. That's how I'd approach pruritus. Is there anything else? Any other question that I have not? Reassurance, both sessions and presentations. Thanks, Meera. Great presenting. Thank you for case discussions. I think anything else, Sridevi? I think
there is no question in the chat. If someone wants to unmute and ask some question before we wind up that?
Personally, for me, I think it's the first time in life I'm interacting with a group like this. I think we should develop some kind of position paper from India for practitioners in this space. There are some guidelines, I know. I think we should be a little more pragmatic. I think we should do this.
I totally agree, Dr. Suresh. I think Dr. Raj also had a lot of intentions on that. I think it's high time that we take it up.
Yeah, we need to do this.
Because many of us struggle in the field without being an expert, or like the questions that came up today is like a very, very practical thing that we see almost every day. So that this is going to be a beginning, I hope.
Indian nephrology is not, Indian nephrology has not done enough in this space. That's my take. Part of my thing came because I did my nephrology training abroad. And I think there's been not just in nephrology, but there's a lot more emphasis on a lot of this. So I think I have, and I can, and I'm also a little bit too sensitive guy. So both of that help me be more proactive in this space. I think we're working on some stuff, even within NephroPlus. We should see how to shape the space. The subset that I would appeal to all this group is, if you see an elderly with a lot of comorbidity, I think dialysis should come well after the fact that you have discussed. Can we keep them going however well for however long without it, but in a balanced manner, and not make them feel abandoned, and not make the family feel helpless, and assure them that you're not doing the wrong thing. The data is there. It's not in an RCT form, but it's an observational study form. That I can tell you. That dialysis doesn't help an elderly, frail, comorbid patient. Definitely not.
Okay, thank you, Dr. Suresh.
Thank you. Thank you much. Thank you all of you.
Dr. Megha also brought up a very good patient story for
Absolutely.
discussion.
Fantastic.
So we also learned a lot from that. Thank you so much, Dr. Suresh. I hope this is the beginning of this discussion, and we'll be taking it forward. We'll be bothering you a lot through emails in the coming days. Thank you so much.
Thank you. Thank you much. Thank you.
Thank you, everyone, for being actively participating in the session. See you next week with another new topic and another faculty.
Thank you, Dr. Suresh, and thank you, Dr. Sridevi. So please don't forget to leave your feedbacks. The link will be shared soon in the WhatsApp. This is Sripriya along with Dr. Suresh and Dr. Sridevi signing off from the Tips Eco Hub. See you in the next session. Till then, everyone take care. Bye-bye.